Welcome, everybody. It's about 2 o'clock, so we'll get started. My name is John Holland. I'm Senior Vice President for Research at AMC Health. And today the webinar is about home blood pressure telemonitoring with pharmacist case management. This was a rather impressive study that was conducted by Dr. Karen Margolis. She's Director of Clinical Research at the HealthPartners Institute for Education and Research. Also with her today is Sarah Groen, and I see an attendee list up there, so I can't actually, there we go. Sarah is a clinical pharmacist with the HealthPartners Medication Therapy Management Program. She was one of a team of pharmacists who managed patients with uncontrolled high blood pressure. If you have any questions or comments, please be sure to keep your phones muted, don't unmute, but send them via a message, which is in the panel on the right side of your screen, and it should be a text message to all panelists. And that way all of us will get that, and at the end of the presentation, we'll handle as many of your questions as we can. At this point, I'd like to turn it over to Dr. Margolis.
Thanks, John. I really appreciate the opportunity to speak to your group today. I don't have any conflicts to disclose. This study that I'm going to discuss today, which we called Hyperlink for short, was funded by the National Heart, Lung, and Blood Institute through an R01 grant. I'd also like to thank the many members of our team who were instrumental in making our study a success, including our co-investigators, project managers, clinic coordinators, statisticians, and last but not least, our intervention pharmacists. U.S. adults with hypertension visit a physician on average 4 times per year, yet only about half have controlled blood pressure as defined by the most recent national guidelines. Practical, effective, and sustainable models are needed to improve blood pressure management in primary care. A few previous studies show that nurse or pharmacist-led care combined with strategic use of telemedicine can significantly improve hypertension management. But those studies have had some limitations, including that they excluded patients with more severe hypertension and comorbidities like diabetes. Many of them were of short duration, and all of them lacked post-intervention follow-up, so it was difficult to know how durable the interventions were. The study design was a cluster randomized controlled trial in adult patients with uncontrolled hypertension, and the patients were recruited from primary care clinics that were randomly assigned to 2 groups. Usual care, in which the patients continued to receive routine hypertension management through their primary care provider, or a telemonitoring intervention which combined pharmacist-led care management and home blood pressure telemonitoring. This study was conducted at HealthPartners Medical Group, which is a multi-specialty group in the Minneapolis-St. Paul area of Minnesota. It's an integrated health system, but our clinics accept all forms of insurance. At the time of the study, we were caring for about 200,000 adult patients with 150 primary care providers spread across 23 primary care clinics. Of those clinics, 16 of them had medication therapy management embedded in the primary care clinics. And medication therapy management, or MTM for short, the pharmacists worked in the primary care teams under collaborative practice agreements with the physicians. And they were able to manage a number of different chronic conditions, including hypertension. And MTM pharmacists work to optimize drug therapy to improve therapeutic outcomes. The study population, as I mentioned, was recruited from the 16 primary care clinics that had MTM pharmacists in place at least 1 day per week. And our inclusion criteria were fairly simple: age 21 or older. Within the last year, the patient's 2 most recent blood pressures in the electronic medical record had to be greater than or equal to 140/90. And then the patient had to come to our research clinic and have a measured blood pressure that was greater than or equal to 140/90 or greater than or equal to 130/80 if the patient had diabetes or chronic kidney disease. We tried to keep our exclusion criteria as minimal as possible so that we could really test the generalizability of this intervention. So we excluded patients if they had had a recent acute coronary event or stroke within the past 3 months, but they were okay to participate if any event that they had was older than that. We excluded patients with severe class 3 or 4 heart failure or advanced stage 4 or 5 kidney disease, if they had a known secondary cause of hypertension, if they were pregnant, and then last, if they had no land telephone line, although later in the study, patients were permitted to participate in the study if they only had a cell phone. The telemonitoring intervention consisted of a home blood pressure telemonitor that transmitted stored blood pressure via a telephone modem. And the patient was asked to measure their blood pressure at least 3 days per week, both in the morning and in the evening. And we did ask them to take multiple readings per session, at least 2 or 3 readings, but we considered them to be adherent to telemonitoring if they sent us at least 6 blood pressure readings per week. The pharmacist was able to access their blood pressure data remotely from the clinic on the AMC website. The pharmacist case management consisted of visits that were primarily conducted by telephone, and they adjusted antihypertensive therapy using an algorithm from the collaborative practice agreement with primary care providers. And they also emphasized lifestyle strategies and medication adherence. The intervention lasted 12 months, and then we followed everyone up for 6 months post-intervention to test the durability of the intervention. So months 0 through 6, the first part of the study was sort of our intensive management that consisted of a 1 in-person intake visit with the pharmacist, and then visits every 2 to 4 weeks after that, depending on blood pressure control. In the second 6 months, the phone visits were spaced out to be every 2 months. And then finally, as I mentioned, in the third phase of the study, months 13 through 18, the patients returned to the care of their primary care provider without telemonitoring, although they were encouraged to continue home blood pressure monitoring without the telemonitoring device. This is our typical visit schedule, and the patient started off coming into our research clinic for the screening visit up here, and then also the patient came into the research clinic visit 3 additional times at 6 months, 12 months, and 18 months. And that was where we did the measurements of blood pressure that we did in everybody, and those were the outcomes that we used for the study. As I mentioned before, there was 1 in-person visit with the MTM pharmacist that took place a week or 2 following the baseline research clinic visit. And then after that, we asked the patients to do the home blood pressure monitoring, telemonitoring, and have periodic discussions by telephone with the pharmacist. So we had the first 3 visits at week 4, 6, and 8 were considered to be mandatory visits that we wanted everybody to conduct. However, after that, if the patient's blood pressure had been under control for 3 consecutive visits, they could then space their visits out to be monthly. So there were several of the visits that were considered to be optional for patients who had become well controlled at their previous 3 visits. So you can see from this that in addition to the 1 in-person visit, that there were 10 potential visits that the patient could make with the pharmacist, 6 of which were mandatory in the first 6 months. And then following that, the visits with the pharmacist were every 2 months at months 8, 10, and 12, and then they had no further visits. This is, I'm not going to go over this slide in complete detail, and it can be found in the design paper that was published in Controlled Clinical Trials. But this is a rough description of the algorithm that our pharmacists were using for drug initiation and titration. And essentially it was following the JAMA recommendation that for initiating treatment with 2 antihypertensive medications if the patient's blood pressure was far away from goal, or with 1 medication if the patient's blood pressure was fairly close to goal. If patients were already adhering to an antihypertensive regimen and their blood pressure was controlled, then they were continued on their present treatment with reinforcement of lifestyle modification, which was really done at all of the visits. And then if patients were taking 1 to 2 medications, we followed a similar algorithm where we tried to add 2 medications if the patient was very far from their goal, or more gentle titration if the patient was close to their goal. If the patient was on 4 blood pressure medications and they were adherent, then the pharmacist was urged to consult the primary care physician and probe the patient very extensively for non-adherence, and consider a workup for secondary hypertension if all else failed. Addressing non-adherence was a major part of all of the different algorithms. And for any patient whose blood pressure was dangerously high, which we considered greater than or equal to 180 over 110, the pharmacists were asked to consult with a physician. And I should emphasize also that we very much emphasized diuretic treatment as either an initial drug or as add-on therapy in patients who are on multi-drug regimens. We collected our data at baseline 6, 12, and 18 months in the research clinic. That consisted of blood pressure, demographics, some self-reported data on lifestyle, quality of life, medications, self-reported adherence, and a measurement of self-efficacy or confidence in their ability to self-manage their own care. For the satisfaction of care, we used 2 different instruments. One was the Consumer Assessment of Health Providers and Systems, or CAHPS questionnaire, which is very frequently used in health systems, and another one called the Patient Assessment of Chronic Illness Care, which was kind of a measure of patient-centered care. We assessed costs of care, including the pharmacist time and the telemonitoring equipment and fee, as well as medications, labs, and other healthcare utilization and expenditures. So our primary aim was to compare usual care to the telemonitoring intervention over 18 months of follow-up. Our primary outcome was a composite of blood pressure control at both 6 and 12 months following the start of the intervention. And as I mentioned, this was measured in a research clinic and defined as blood pressure less than 140 over 90 or less than 130 over 80 if diabetes or kidney disease was present. And we also evaluated some other outcomes, blood pressure control at 18 months, change in systolic and diastolic blood pressure, satisfaction with care, and costs of care. Our analysis was conducted by a statistician who had a lot of familiarity with the complex design of the study, and I'm not going to go over all of these details, but essentially the analysis accounted for the clustered randomization at the clinic level and the repeated patient data collection. And also we had procedures for handling missing data and also for adjusting for the multiple comparisons that were made involving the key endpoints. So this is an overview of our patient recruitment. HealthPartners is a large system, and we identified almost 15,000 patients who met our criteria of having the two most recent blood pressures be greater than or equal to 140/90 in the electronic medical record. Of those patients, we received a response from a patient who was interested in the study and conducted a telephone screening and also in-person screening. And of these 2,000 or so patients, roughly about 40% were ineligible for the study, mostly because their blood pressure was actually under control when we measured it in the research clinic. And then there were a variety of other exclusion criteria like the landline and medical conditions. And we had a bunch of patients who, once they heard more about the study, decided that they didn't want to participate or didn't show up for their scheduled visit. So we ended up with 450 eligible patients who were linked to our 16 clinics, and of these, 228 were in the intervention clinics and 222 were in the usual care clinics. Our baseline characteristics were the average age was about 61 years. About half of the patients were female. 82% were white race, and 2% were Hispanic ethnicity. It was a well-educated group with 48% having a college degree or higher. More than half of the subjects were obese, which is fairly typical for the hypertensive population. And we had a lot of patients with comorbidities. 10% had a history of cardiovascular disease, and about a third had either diabetes or kidney disease or both. The initial blood pressure at randomization was 148/85 in both groups. And these baseline characteristics were very well balanced between the two treatment groups. The only one that differed statistically was Hispanic ethnicity, which was a little higher in one group than in the other. So these are our key results, starting with blood pressure control. So everybody in the study started off with their blood pressure being out of control, and by 6 months time point, about 72% of patients in the telemonitoring intervention, the blue bars, reached blood pressure control. And this stayed surprisingly constant over the 12-month and 18-month time points, despite the fact that the intervention stopped after 12 months. What we observed in the usual care group was a slower, more gradual increase in blood pressure control, starting at 45% at 6 months, 53% at 12 months, and then up to 57% at 18 months. But at all time points, the blood pressure control was much greater, highly statistically and clinically significant in the telemonitoring intervention group. This next slide is showing our composite blood pressure endpoints. And again, at baseline, everyone was uncontrolled. And the second set of bars shows people who were under control at both the 6 and 12-month time points, which was our primary endpoint of the study. And here we found that 57% had blood pressure under control at both time points compared to 30% in the usual care group. So almost twice as many patients had achieved blood pressure control in the telemonitoring intervention group. If we include the 18-month time point in our composite, the blood pressure controls dropped slightly in the intervention group to about 51%, and was only 21% in the usual care group. And again, there was more than twice as large blood pressure control in the intervention group. This slide shows our change in systolic blood pressure over time, and everyone started off at a roughly 148 for systolic blood pressure. At 6 months, blood pressure had dropped by more than 20 points in the telemonitoring intervention to 127, but had declined far less to 137 in the usual care group. And then, again, blood pressure Systolic blood pressure stayed quite constant at 12 and 18 months, around 126, 127 in the intervention group, and it declined gradually to 135 and 133 in the usual care group. And again, this the difference, 10, 9, and 5 or 6 millimeters of mercury, all three of those were highly statistically different between the two treatment groups. Similar findings for our diastolic blood pressure, starting off at about 85 and declining about 10 points in the telemonitoring intervention group to about 75 and staying fairly constant over time, with a smaller and gradual decline in the usual care group. And the final difference at 18 months was only 4 millimeters of mercury, which was just borderline in terms of statistical significance. But again, at that time point, the intervention had been stopped for 6 months. This slide is kind of busy. It shows a selection of some of the other study outcomes that we looked at, both sort of process measures and some of those measures of patient satisfaction and lifestyle. And what I've done is I've highlighted the results that show a strong less than 0.001 difference between the telemonitoring group and the usual care group, and the ones in blue are still statistically significant at less than 0.01, and then the bold ones, the slightly darker, are also statistically significant, but at less than 0.05. So for hypertension medications, the patients were on an average of about 1.5 medications at baseline, and at 6 months' time, that had increased sharply to 2.2 medications in the telemonitoring intervention group, and stayed constant throughout the rest of the study at that level. There's a slight increase in medication treatment in the usual care group, up to 1.6 and 1.7 throughout the study, but again, these differences were very large and statistically significant. We have some measures of self-reported adherence available to us right now, and about 2/3 of the patients reported what we called perfect medication adherence on a four question survey instrument called the Mariski. And we did have a signal of some slightly higher self-reported adherence at 6 months in the intervention group, but that was not statistically significant at the other 2 time points. About half of our participants were using a home blood pressure monitor in the 12 months prior to the start of the study, and during the intervention period at 6 and 12 months, almost everybody was using a home blood pressure monitor, since this was a key part of our intervention. And that was very different from the usual care group, where there was very little additional adoption of home blood pressure telemonitoring. And at 18 months, about 70% of our intervention group was still using a home blood pressure monitor, even though the telemonitors had been collected. We had some places where patients were reported improved satisfaction with their care. I don't have those listed here, but patients felt that they had a greater ability to be in touch with their healthcare team. They also had felt more confident that they could include home blood pressure monitoring in their weekly routine. And this was on a 5-point scale, so it was fairly high at the beginning of the study, but it increased even further in the intervention group relative to the usual care group at both 6 and 12 months. Also, on this same 5-point scale, confidence that the patient was able to keep their blood pressure under control improved from about 3.8 to 4.2 on that 5-point scale, and remained fairly high throughout the study in the telemonitoring group, probably reflecting the fact that they were keeping their blood pressure under control. And then finally, just a couple of things from our lifestyle measures, patients did report a drop in the percentage who were adding salt to their food at the table or during cooking. So about 20 to 25% said they were adding salt to their food at baseline, and that declined to more like 10 or 15% in the intervention group throughout the study. We did do some careful collection of adverse events, as would be normal for any clinical trial. We found 60 adverse events in the usual care group and 49 in the telemonitoring intervention. And these were mostly non-cardiovascular hospitalizations, so things like elective surgery or people coming in for COPD exacerbations. But in looking at the events that were possibly related to the study intervention or to cardiovascular events, we found 2 allergic reactions to blood pressure medications, both of which were in the usual care group. There were 7 events that were related to hypotension, so dizziness or near syncope or even syncope, and 6 of these were in the telemonitoring group, and all of those were in patients who had the lower blood pressure goal of less than 130/80, which may not be especially relevant now. There seems to be a movement towards relaxing the blood pressure goal in patients with diabetes and kidney disease. We observed 7 strokes, 5 of which were in the usual care group, 3 TIAs, all of which were in the usual care group, 2 episodes of atrial fibrillation requiring hospitalization, 1 in each group, 1 myocardial infarction in the usual care group, 1 hospitalization for unstable angina in the telemonitoring group, and 2 coronary artery bypasses, both of which were in the usual care group. So despite the fact that we didn't power this study for cardiovascular events or really expect that in this 18-month period we were going to see much of a signal there, there does seem to be at least an encouraging trend towards fewer serious cardiovascular events in our telemonitoring group. We had some preliminary data on intervention costs. Our direct estimate was per patient was just over $1,000 for the 12 months of intervention, and about half of these were program costs for the MTM pharmacist services, their time spent interacting with patients and taking care of charting and communication with the primary care physician. The intervention patients averaged 11 visits with their MTM pharmacist over the course of the study, and the visits, including the time that the pharmacist spent preparing and charting, were just a little over 30 minutes on average. The other half of the program costs were for the telemonitoring services. The intervention patients used telemonitoring device and data transmission service an average of 10 months each. And as we've been doing some preliminary looking at whether this long duration of monitoring was really necessary for the majority of patients, where we have some preliminary data that suggests that most of the patients' blood pressure control occurred far earlier in the study, probably within the first 3 months. Under prevailing market rates, we estimate that the program costs, as we conducted the study with all these visits and all of this intensive long duration of treatment, would be $1,350 per patient. We're doing some further utilization and cost effectiveness analyses that will include medications, labs, and other healthcare utilization and expenditures, and we hope to have those ready to report soon. So just to put this study in perspective, I'll just mention a few other fairly well-known telemonitoring or similar blood pressure treatment trials. There's a study by Bosworth et al. That was published recently in 593 patients for 18 months, and this was a factorial trial that involved both blood pressure telemonitoring with nurse led care, and also another group received behavioral intervention, and some groups received actually both. And they did observe a differential in blood pressure control, with higher control in the intervention group and lower systolic blood pressure in the intervention group by about 4 millimeters of mercury. And another interesting study by McManus et al. Was conducted in the UK, and this was a study that used telemonitoring and instructed patients to actually self-titrate their own medications based on 1 or 2 moves that were agreed on ahead of time with the primary care physicians. And that study didn't actually report blood pressure control, but it did show a difference in systolic blood pressure between the 2 groups of 5 millimeters of mercury. Beverly Green at Group Health in Seattle did an interesting 3-group study that was published in 2008 that was in a lot of ways very similar to the hyperlink study, but in this case, instead of using home blood pressure telemonitoring, they had the patients use secure email through the health plan portal to simply email the pharmacist with all of their blood pressure readings. And that study showed fairly similar results to ours at 12 months, with more than twice as many patients in the intervention group achieving blood pressure control and about a 9 millimeter of mercury difference in systolic blood pressure. And then finally, McGidd et al. Did a very similar study to ours at Kaiser Permanente in Colorado. This study was a very pragmatic study that used somewhat fewer resources than ours, and used a health portal as well with the home telemonitoring. And it only lasted for 6 months, but they did also see a big difference in blood pressure control between their intervention and control group, with a 12 millimeter of mercury difference between the 2 groups. So our conclusions are that home blood pressure telemonitoring with pharmacist-led care management was safe and highly effective at improving blood pressure control and lowering blood pressure over 12 months. The improved blood pressure in the intervention group was maintained for 6 months after the end of the intervention and return of the patient to primary care. And while this intervention was resource intensive, we think that the costs may be reduced by better targeting, individual tailoring, and negotiating discounts on telemonitoring. This intervention may be cost-effective for managing patients with uncontrolled blood pressure, especially if the results that we observed are sustained during longer follow-up. And we are doing a long-term follow-up study with our patients for up to 5 years, and this just started in re-enrolling the patients this month. So thanks very much for your attention, and we would be happy to answer any questions that you have.
Karen, thank you very much. I just want to note that there was an accompanying editorial to this article in the Journal of the American Medical Association, in which they said that this was really a taste of the way blood pressure will be managed in the future, and that office management really is not the optimal way to do that, and that what you've done really shows a better way to do things. So thank you for the study and for the project itself, and for running this webinar on it. We have a few questions. One person asked if you if you know the percentage of African American patients in your population.
It was about 18% in the study overall.
Okay. Another question. This may be to Sarah. What sort of special training did you have as a pharmacist in medication management?
All of the pharmacists in our group are residency trained, and all of us have our PharmDs and go through training initially in the program when we were hired many, many years ago. So I guess that would be the training we've had.
Okay, another question that came up is, When you, we saw a slide about the algorithm for what you do when, but was this based on 1 or 2 readings, an average over a week? How did you actually view the data and know when it was time to make a change?
The data was provided at those visits, and it was the average of those readings that determined whether we would adjust therapy at those visits.
Okay. Another question that just came in, have you considered text messages for use in the future?
I'll take that question. There's a lot of interest in our health system in all different kinds of e-health, and we are using text messaging for a variety of other conditions, reminders for immunizations, and also maybe for some more lifestyle-oriented interventions. We haven't begun thinking about that yet for hypertension, but I think it could very well play a role in the future for some simpler things like reminding patients to pick up medications, et cetera.
I would add that we're looking at ways of using text messaging to collect all sorts of symptoms and behavioral issues. Security is an issue with text messaging, but there are a number of secure applications for that. Here's another question that just came in. Do the pharmacists use the web to relay messages back and forth, or is it mainly telephone? And I assume this question means messages to patients. So were you doing it online or by email or doing it mostly by phone?
It was by phone consultation. If we do have some patients that do use through the electronic medical record system that we are able to send messages, but it wasn't a requirement, and I would say the majority of our patients, the visits were all telephone. But if some patients did choose to communicate in between those visits, especially with medication adjustments, with questions, if they did have the online patient services active, they could contact us that way.
Okay. Karen, this may be a quick, go ahead.
Yeah, I would say also that if somebody's interested in that type of an intervention too, this paper by Beverly Green that was in JAMA 2008 describes, a system that was entirely conducted via webmail.
Mm-hmm. Karen, this is probably for you. You reported on patient satisfaction, and I imagine then you didn't do a formal survey with the PCPs, but do you have any informal sense of whether they liked the system, felt threatened by it, felt supported by it?
I think that we've had MTM pharmacists in the clinics. It's been about 4 or 5 years now. Is that right, Sarah?
4 or 5 for all of them, but we've been in the system for 8 years.
Yeah, and I think that initially, HealthPartners, the physicians actually, at least in the past, have mostly been working on a fairly fee-for-service oriented system, and I think there might have been some initial feeling that there might be some competition with the pharmacists for patients, but I think that very quickly the physicians learned that the pharmacists were taking the burden of some of their most difficult patients who have really serious issues with multi-morbidity and polypharmacy, and actually helping to get those patients under control so that they could come back for fairly simple visits with the physicians and not take an hour, out of the day when, only 15 minutes is really scheduled for that patient. So I think most of our physicians are fully on board now with appreciating and referring patients to the MTM pharmacists.
Along that line, if a pharmacist does a telephone consult with the physician, is the physician reimbursed for that phone consultation?
No, the physician at this point, usually that was in all likelihood, a face-to-face conversation with the physician or an email conversation between the pharmacist and the physician. So while we do have some capability now to be doing email visits and telephone visits, that really wasn't enough of a system to be part of this study. But I do think in the future that some of this could be, under some of the patient-centered medical home, I do think that some of these services could be billable.
Mm-hmm. And Sarah, just to get a perspective on this, out of 220 odd intervention patients, how many, or I'm not sure how many you took care of, so out of your panel, how many times would you actually need to consult with the PCP as opposed to be able to simply work from the pre-approved algorithm?
I would say in my population it was probably 80% was straight from the algorithm, because at that time our algorithm was to consult providers for any medications, number of medications greater than 4, and there were some patients that we had to use 5 medications with some of our more challenging cases. And in those cases, then we were required to consult the provider for approval. But I would probably say 80-20, just in my population, and I probably had 40 to 50 of the patients.
Karen, just this is actually a question from me. You are looking at overall cost of care in the two groups, because if in fact the number of serious events is meaningfully different, then the cost of care should also be meaningfully different.
Yeah, that's true, although, it's that those costs, even though they're very great, they do affect just a small number of patients. And so, our economists do have methods for sort of dealing with with outliers and the very skewed. They're, usually economic evaluations end up having a few patients who really cost a lot of money, and then most patients, are sort of way down at the other end. So I'm not positive how those economic evaluations are going to come out for just the short term. But if those trends would continue over a longer period of time, I do think that there could be some cost savings associated with reduced cardiovascular events.
And I also think one of the things that is to be remembered is we had, as a pharmacist, had to document in multiple systems, some of it with our own medical record and some of it with study information. So I think when you look at some of the time, that would probably also be different when you extrapolate that out.
Mm-hmm. So you're saying in practice might take a little less time than it did for the study?
I would assume so, because you wouldn't have to do twice the amount of documentation. You would document in one system.
Sure, makes sense. Any other questions from people who are attending the webinar? Get your questions in now. There's a question that somebody just asked. You're looking at reduction of blood pressure. How does that translate to, say, reduction of Framingham risk, for example?
Well, that's an interesting question. And the Framingham risk equations were really, not really very well set up for assessing treated patients. So, for example, if somebody has a blood pressure reduction but a medication is added, the Framingham risk may not really reflect that well their actual change in risk. So I think it's hard to use. The Framingham equations to really follow patients. But I think that we know that a 10 millimeter change in blood pressure is going to really, if that's sustained over a long period of time, we know this from big meta-analyses of treatment trials, that that's going to translate into a large reduction in stroke risk. So I don't know the exact answer to that specific question, but I feel pretty confident that a sustained reduction of 10 millimeters of mercury of systolic blood pressure would almost certainly be sparing patients the morbidity of strokes and some MIs as well.
Okay, here's a question. Do you feel that data transmission, the telemonitoring, I guess, is essential for these kinds of results, or would it be equally effective with self-reported blood pressure results along with the pharmacist intervention?
I think it's way better with the telemonitoring because you get all of the data. I find in both hypertension and also diabetes, a lot of times when patients are self-reporting, they're self-reporting positive results, and sometimes because they want you to be pleased with the results of their readings, so they won't always give you those higher readings, or they'll just give you a small snippet. So I think it gave us a better data of exactly what time, what date, because when people bring in home readings right now, they don't tell me what time it is. They may not know what was going on at that day. They can't remember what was happening and going on, whereas when it's graphed out and we can see trends, I think that you get better overall impression of what's happening from a day-to-day basis.
I would also add that there are at least 3 published studies in which patients were asked to measure and report blood pressure and or blood glucose, and in all of them they were given memory monitors but not told that the monitors had memory, and half to 3/4 of the patients in these studies made clinically significant errors or edits in their reporting of their readings. The most common were getting better readings than you actually had. We all want to be good. We all want to be good students. And then there were a few people who were actually reporting worse readings because they were trying to convince a spouse or a disability board that they were sicker than they really were. So self-reported readings are not considered terribly reliable. Somebody asked if you would describe the value of the one-on-one intervention in the results. That's a big question, of course, but just give us a sense, if you would, and either one of you or both of you, as to how the value of that would compare to, let's say, an automated algorithm that would suggest to people that if they had a blood pressure at this level, this is what they had to do.
Well, I think there's a lot of variables that can affect a person's blood pressure, and working with that patient and trying to tailor the consultation to that patient's needs definitely improves results. And you get to know these patients, and I think partially because when you're talking about the medications and the side effects and the visit is keyed in on that with someone that they consider to be a drug specialist, is that they trust your opinion, they trust your judgment, and they're more likely to adhere with the therapy. And patients were more likely to also report when they had side effects and contact me because we were accessible.
Okay, another question. How do you manage issues with things like blood pressure technique and other confounding factors, smoking, activity level, the timing of the reading? I guess there's a follow-up to that, which is, were there many instances where the issue was poor 24-hour control versus overall daytime? Although, since you were not using 24-hour monitors, I don't think you actually have an answer to that. Did you ever do things like have patients do pre and post medication administration to see what the change in their blood pressure would be after they took their meds? So that's a long compound question.
Okay, so where's the first part was?
How'd you deal with confounding issues? Activity level, smoking, things like that.
Patients were trained initially before they started their telephone visits. They would get their kit that was mailed out to them. They would bring that kit into the clinic, and we would do an extensive training as well as their initial assessment on how to use the monitoring equipment. So we went through all that, the making sure the activity level smoking as it relates to time, making sure that they had proper cuff placement and that they had proper cuff size, and then also train them on how to transmit the data. So that was part of that initial in-office 1-hour visit that they had with the pharmacist. No 24-hour monitoring, so I guess you're right, we can't really comment to that. And what was the last part?
That was pretty much it. I'm sorry.
Okay.
Just on the 24-hour thing, just so that everybody understands, these are blood pressure monitors that the patient puts on their arm, presses a button to take a reading, and then takes off. It's not something that's worn either all day for a daytime ambulatory or 24 hours for a 24-hour ambulatory. But there was another question about, did you ever have patients do a pre- and post-medication blood pressure to kind of get a sense of whether taking their meds and then waiting however long it took for the medication to kick in would make a difference?
No.
Okay.
We didn't look at that as part of the study.
Right. There is sort of a theory or an interest in whether nighttime medication administration would control some of the nocturnal blood pressure and early morning blood pressure surge. And we didn't experiment with that in this study, but I think it's an interesting clinical question.
Okay, so the person who had asked about the daytime versus nighttime just clarified it, saying that she didn't really mean 24-hour. She meant some degree of looking at early morning or evening BPs. Did you see the typical, this is me adding to the question, did you see the typical circadian cycle of higher readings in the morning and then lower just before bed? And did you see any difference, say, in patients who were well controlled from those who weren't? Which goes back to what you were talking about, Karen, about the nighttime dip.
Well, I think it's separate. It's been a long time since I've looked at this, the data that was transmitted, because the study was a while back when we were doing the telemonitoring, but I believe it broke it down into AM and PM, if I'm not mistaken, where you could look at the differences between the two. So if we saw that there was a particular time during the day that they were getting spikes, that we could adjust therapy accordingly. And I think there was also a graphic that very similar-wise that you could look at to see if there were any trends of that nature, because it did transmit time, so you were able to determine if there was a certain time that they were having elevations during the day.
Yes, you're right. The website showed that. The other thing that the website did, which I think was done specifically for your study, was it reported the percent of readings that were out of goal. So that in addition to looking at specific readings, you got an overall, it's a little like looking at area under the curve, and you had an overall sense of just how many readings on a percentage basis were out of range as opposed to being in range. We have a few more minutes and a few more questions here. Did you find a different medication, that different medications were more effective in African American patients? And was there anything in your protocol that was specific to African Americans?
Well, because we really emphasized using diuretic treatment for as many patients as possible, that would be an effective regimen for African American patients. And I think our pharmacists were well aware of the data that suggests that when used as monotherapy, that ACE inhibitors and beta blockers may be less effective in African Americans. So I think there was a strong tendency to try to work more with medications that have been shown to be more effective on average in that population. I mean, that being said, though, every patient is going to be different, and some patients don't respond well to a regimen that, at least on a population average, they, quote, should respond well to. And so we tried to make sure that every patient was treated as an individual. But I think our algorithm would work well for patients of all races and ethnicities.
Okay, we do have time for a few more questions, but I won't leave it till the very end. Several people have asked about whether they could see these slides. And I'm not sure how long it'll take, but they will be available on the AMC website. There'll be a link to this, including the audio. I think by the end of the week that should be available. Here's kind of a follow-up to the question about different meds for different populations. Did you look at insurance and formulary coverage for meds? Generics, copays, what Medicare covered, and did that have any impact on what meds you used? In other words, were you trying to specifically go for generics? Were you trying to stay within somebody's formulary? Did you discuss these decisions with your patients?
Well, fortunately for most of the classes that you look at that we would use initially, there's generic options readily available. So I would say in most cases when generics are available that they were utilized. And a lot of our patients do have HealthPartners insurance, and we're very familiar with the formulary, but I would say that we didn't really have a lot of insurance issues. It's something we always look at with our patients, safety, effectiveness, and are they going to be able to obtain the medication? Is it affordable? So it was something we looked at with patients. And patients are becoming more educated consumers as well, and I think a lot of patients are requesting that now as well.
Okay. Someone asked, what percentage of patients needed a workup for secondary hypertension? Was that common, rare?
I would have to say that it was 0. I would imagine that I would have known about it, and I'm not aware that any patient was referred for like hyperaldosteronism or renal artery stenosis. Sarah, are you familiar with any patients that you referred?
Nope, I did not have any.
Okay.
We excluded anybody for that, so people worry about it a lot, but it's not very common.
Mm-hmm. And one would think that after going through your algorithm, and if you were still failing to get good control and you were confident that adherence was good, that would be a good indicator that one of these things is going on. So it might be actually a way to catch it. Another procedural thing, we have a short survey at the end of this presentation. We hope that you'll all stay on and do it. It'll help us improve the quality of these things. I'm sure Karen and Sarah would appreciate your feedback as well. I think we're pretty much out of questions. So, and we're just about out of time. So we'll stop 2 minutes early, which will give you all ample time to participate in the survey. How do we get to the survey?
Once they exit.
Oh, when you exit, you'll be requested to do the survey. It's pretty short, and again, we'd be very grateful if you do it. Thank you very much to Karen and Sarah. Thank all the people who participated. We had a really good set of questions. I hope that it was valuable for all of you. Your questions certainly helped focus this whole presentation very nicely. So thanks very much.